Welcome to Bite Medicine's 49th webinar. It's an absolute pleasure to teach you guys, and I'm glad we've come so far. For those of you who don't know me, my name is Shoaib. I'm one of the co-founders of Bite Medicine, and this week we'll be covering a combination of various hematology topics and general surgery topics. Just a few announcements before we get started. We've had a few technical issues over the last day or so with our website, so if you haven't been able to log on, I do sincerely apologize for that. We are working to get that fixed, and the website is now back live. So I do apologize if you couldn't get onto your account yesterday, but it's mostly sorted now. And the other thing is, as always, if you fill out a certificate at the end of a live webinar, you are eligible for a certificate of attendance from our friends at Medigate. So please do stay tuned till the end, fill out a feedback form. And yeah, without further ado, let's get started. So aims and objectives of this lecture. It's a lecture on anemia, obviously. So we are going to be covering various topics. But what I wanted to know from you guys is, a lot of you have actually asked us to do hematology. So I wanted to know why is it that you find hematology useful? Just jot down a few things in the chat. It'd be really useful to know why hematology is such a difficult topic. A lot of things which come up, it's not covered well. Okay, that's interesting. Barely covered. Nobody can teach heme malignancies well. Okay, yeah, so I agree with all of those. I initially found hematology really difficult at the beginning of med school, but I realized actually hematology is really interesting, and actually it's not that hard. There's nothing complex in hematology. It's just you need to be able to classify things, and it's like renal. So we had a renal series last week, I think it was, and everyone finds renal difficult, but actually it's quite easy once you categorize things into their appropriate boxes. And it's much the same with hematology, anemias, malignancies. Once you have a way of classifying things into their different boxes, it becomes really easy actually. And that's what I'm hoping to do, is simplify hematology for all of you. This lecture will last 60 to 70 minutes, and the slides and recordings, slides are already up. And the recording of this hopefully will go up onto app.bitemedicine.com. I know a lot of you have logged in via our website, so if you're having any issues, just mention them in the chat and one of the admins will get to you. Good, so let's crack on. So this is our first case. Have a read, and then we're going to pop onto a question on Menti. So we have a young lady, 20 years old. She's masked up because it's COVID season, and she's come in with lethargy. She's a medical student and complains of intense fatigue, struggling to stay awake during lectures. Please don't say what you think the diagnosis is in the chat, because we're going to come to that. As soon as she gets home, she goes straight to bed normally, okay? And she reveals that she often has heavy periods. And so are we worried about this lady or not worried? So a bit worried. Okay, I wouldn't, yeah, I mean, fair enough. Young ladies come in with symptoms can be concerning, but our observations are all pretty okay. That's fine. So this is the question. Please do not answer this in the chat. I'm going to pop over to Mentimeter, and you should be able to answer it there. So which of the following is the most likely type of anemia in this lady? So she's a young lady with heavy periods. That's all you really need to know. If you go to menti.com and pop in the code at the top, I should have hidden the answer, that's my bad. Okay. So which of the following is the most likely type of anemia? Microcytic, normocytic, or macrocytic? Yeah, I didn't really hide the answer there, so that's my bad. But it seems like most of you have got the gist that this is a microcytic anemia. What is the cause of this anemia here? IDA, what's IDA? Yeah, iron deficiency anemia, good. That is a microcytic anemia, okay? So we had a 20-year-old lady coming into the GP with heavy periods. Chronic blood loss through menstrual bleeding leads to iron deficiency, and iron deficiency is the commonest cause of anemia worldwide, okay? About 500 million people worldwide have iron deficiency anemia. It's not normocytic because it's microcytic, and likewise it's not macrocytic. Megaloblastic is a subtype of macrocytic anemia, and aplastic anemia is a cause of normocytic anemia. So this is a iron deficiency anemia, which causes microcytosis. You may not have a clue about what I'm talking about, but we're going to explain exactly what that means. So in order to understand anemias, we need to actually understand what hemoglobin is. Hemoglobin is really simple. It consists of heme and globin. You know, that's as the name suggests. 4 polypeptide globin chains, and each of those chains is bonded or complex to a heme molecule. Heme is just an iron complex, okay? It's an iron-containing compound. So if you look at this diagram here, we have 4 chains, 2 beta chains and 2 alpha chains. That's the most common construction of hemoglobin, with 2 beta and 2 alpha chains. And then in the middle of those globin chains, you have this yellow iron molecule called heme. So it's heme plus a globin chain, and then you have 4 of those. That makes up hemoglobin. And that's really important to understand, because all anemia is a reduction of the heme or the globin or both. So it's either reduction in the iron containing part or the polypeptide globin chain, or both of those. And these are the HB variants here. I don't want to dwell on this too long because we're going to touch on it in a lot more detail later on. But basically you have HbA, which is the most common type of hemoglobin seen in adults. And it consists of 2 alpha chains and 2 beta chains. And then you have 2 rarer forms of hemoglobin, which are found in lower proportions within our blood. And that's 2 alpha and 2 delta chains makes up HbA2, and 2 alpha and 2 gamma chains makes up HbF. Okay, so all 3 of these are found in adult blood. HbA is the most common. The bottom 2 are less common. This is very important to understand when it comes to things like sickle cell disease and thalassemia. So you must make sure you memorize that, and you need to know that for your exam. Okay. So according to the World Health Organization, anemia in men is classified as an HB of less than 130, or in women as less than 120. And we can further classify anemia based on the mean corpuscular volume. So what is the MCV? What does that actually mean in layman terms? Yeah, it's basically just the size of the red blood cell, to put it simply. That's just a fancy name of saying the average total size of the red blood cells. So size, mean corpuscular volume, MCV just means size. And we can split anemias up into microcytic, i.e. small blood cells, normocytic, i.e. normal blood cells, normal sized blood cells, or macrocytic, i.e. big blood cells. And when I was making this PowerPoint, I realized that I can't actually go through all of anemia in one lecture. So I'm going to focus today on microcytic anemias, and then we'll have further parts to cover normocytic and macrocytic. So if we look at the microcytic column here, that's an MCV of less than 80. 4 conditions that you must memorize and know for your exams: iron deficiency, thalassemia, anemia of chronic disease, and sideroblastic anemia. Anemia of chronic disease can also cause a normocytic anemia. Sideroblastic anemia is very rare, but it does come up in MCQ questions, so you do need to know about it. I've never seen it once in clinical practice, but it's just something that comes up in exams. And then you have your normocytic and macrocytic causes, which I won't dwell on too much right now because we'll have in-depth lectures on each of those. Someone said lead poisoning. So lead poisoning causes sideroblastic anemia. General principles. So it doesn't matter what the cause of anemia is. if the anemia is significant enough, it will cause these symptoms, okay? It doesn't matter if that anemia is due to iron deficiency, it doesn't matter if it's due to thalassemia, to sickle cell, to B12 folate deficiency. If the patient is anemic, they will be fatigued, they will be short of breath on exertion, they may have chest pain, okay, because the heart is having to work extra hard to deliver oxygen around the body. And again, they may have palpitations, again, because the heart is working extra hard to push oxygen around the body. If the anemia is very severe, they may be tachycardic, they may be hypotensive, they may be visibly short of breath at rest, and they may have pallor. So pallor just means pale. Often we look for that on the palms or in the eyes. So palmar, crease pallor, or conjunctival pallor. Okay. And these are general anemia symptoms across every cause of anemia. The patient has a low hemoglobin, they may have some of these, of which fatigue is probably the most common. So fatigue, lethargy, being very tired, that can cause, the anemia can cause fatigue, yeah. And this is more a point for your OSCEs in your clinical practice. So anemia can definitely come up in your history taking stations, and some things to bear in mind. This is not a detailed list, but always explore the symptoms of anemia, things we just mentioned, shortness of breath, chest pain, palpitations, etc. Screen for areas of blood loss. So gastrointestinal, what questions are you going to ask the patient if you're worried about blood loss through the GI tract? What are the really important questions? Yeah, weight loss, blood in stool, but specifically, what about blood in stool? Yes, is it black or is it fresh? Okay, does it look black, which suggests it's an upper GI bleed, or is it fresh, which suggests it's coming from lower down? Then for respiratory causes, you just ask them, are you coughing up any blood? For a urinary tract, you can ask them if they're peeing out any blood, and you must take a full menstrual history. A lot of young or middle-aged ladies are anemic because of menorrhagia or losing blood through the through menstruation. So you must take an in-depth menstrual history. Very common cause of iron deficiency anemia. Screen for alarm symptoms. So malignancy can also cause anemia, weight loss, loss of appetite, night sweats, lymph nodes, all the common things you would normally ask for in a cancer history. Ask them about their diet, because obviously iron is important, B12, folate, these are all important parts of your diet, which can contribute to an anemia. And then explore the past medical history, family history, if there's any inherited disorders like thalassemia or sickle cell disease. And then you'd go on to conduct the rest of your history. Again, general principles, investigating an anemia. I don't want to dwell on this too long because we're going to go into the specific causes, but of course you're going to start off with a full blood count, look for the hemoglobin, look for the mean corpuscular volume, blood film, iron studies, your vitamin and folate levels. If you're worried about a hemolytic anemia, you could conduct a hemolysis screen. Chronic renal failure, liver failure, and hypothyroidism can all cause an anemia. And then, if you're worried that the patient was acutely bleeding, for example, in trauma, of course, you would do some imaging. If you were worried there was a problem with the bone marrow, you could do a bone marrow biopsy. These are all general principles. Again, when we come onto the specific conditions, I will narrow down exactly what investigations you need to do. Okay, so if we first take a look at iron deficiency anemia as a cause of microcytic anemia, definition is it's either due to reduced intake, increased requirement, or increased loss of iron. It's the most common cause of anemia worldwide, affecting 500 million people according to NICE. So, that's a significant amount. Now, I have a feeling that's probably a bit of an underestimation, but regardless, 500 million is a lot. And these stats vary according to what papers I looked at, but 3% of men and 8% of women in the UK are affected by iron deficiency anemia. Some statistics even go as high as saying, more than 20% of women in the UK are affected by iron deficiency anemia. So a very common problem that you will definitely see as a medical student, probably on day one of being being in the hospital when you're an F1. Can you name some causes of iron deficiency anemia for me? So we've already said menstrual loss and menorrhagia. Are there any other common ones that you can think of? Poor diet, colon cancer, good. Celiac disease, diet. Okay, we've got some good suggestions here. Worms in gut. Yeah, that's actually quite common in other parts of the world. Okay, let's look at the pathophysiology. So iron deficiency anemia, what's going on? So if we look at what normally happens, so I eat some iron, I'm gonna, for example, meat is a rich source of iron. So I eat some meat, the iron in that is absorbed in the duodenum, it's transported in the blood bound to a protein called transferrin, and it's stored within cells bound to a compound called ferritin. So very simply, you eat it, it's absorbed in the first part of the small bowel, the duodenum, it's transported bound to transferrin, and it's stored with ferritin. These are all really important words to remember, transferrin and ferritin, because we measure these, or we can measure these, when it comes to investigating an iron deficiency anemia. Now, what actually happens in disease? So for some reason, I have a lack of iron, okay? That can be due to a number of causes, which a lot of you mentioned in the chat and we'll get onto, but for whatever reason it is, you have low iron, you have reduced heme, therefore reduced hemoglobin and a microcytic anemia. Going back to the structure of hemoglobin, these yellow things complexed with the globin chains are iron-containing compounds called heme. If you don't have enough iron, you can't make enough heme, you can't make enough hemoglobin, and your red blood cells are therefore small, and you are anemic. Very basic pathophysiology, okay? So there's two ways you can classify the causes of iron deficiency anemia. I prefer to do it like this by age group, because it's what you're going to see in your exams, because they'll say, you know, a young child or a 20-year-old lady or whatever it might be. And it's the best way to categorize it. And it's what you're going to see in clinical practice as well, because you're going to have real patients in front of you. And that demographic information really gives you good clues as to what the underlying cause is. So in infants, so we're talking babies here, you know, first year or two of life, malnutrition and breastfeeding are the common causes. Why does breastfeeding cause iron deficiency? Yeah, so breast milk is a poor source of iron. So where women can, they should always, or they should try to breastfeed, because it's shown to have significant benefits over formula milk, despite what the formula companies might say. Breast milk is far superior. But one of the downsides is that it has less iron, okay? So there is a risk of developing iron deficiency. In children, again, malnutrition. Malnutrition is a cause of iron deficiency in pretty much every age group. If you have a poor diet, you may develop iron deficiency. But particularly in children, they may have malabsorption conditions, and there are a number, but one of the most common ones is celiac disease. And if you remember, celiac preferentially affects the duodenum and the jejunum as well. And iron is absorbed in the duodenum. So celiac is going to knock out your iron absorption. In adults, we're thinking more things like peptic ulcer disease, menorrhagia, of course, if it's a lady, and again, malabsorption conditions. And finally, in the elderly, if you have a new iron deficiency anemia, that is colon cancer until proven otherwise. So in an elderly patient with iron deficiency anemia, that must raise a red flag for colon cancer, because colon cancer sits in the gut wall and slowly leaks blood into the stool, and these patients gradually lose iron and they gradually become anemic. So that's not a good sign. Good. Now, that's the way I like to classify it, and we will come on to a slightly different way to classify it later, but I think this is much better. But before we do that, let's go on to a question. So remember that case about the lady with menorrhagia, and we pop over to Mentimeter. So we know this lady now has a microcytic anemia. Which of the following tests should be conducted next if you suspect iron deficiency? So if you don't know, if you never used this before, go to menti.com and type, it will ask you to put in a code, put the code in at the top. And it's probably easiest if you do this on your phone. So we have serum iron, transferrin, ferritin, total iron binding capacity, and urinary iron. So someone has said pregnancy can cause iron deficiency anemia too in the chat, and that's true, it can, because the baby consumes iron. Okay, most of you have gone for ferritin. Good. This is important. This is a nice guideline. So nice say you go for ferritin first. And that's something that could definitely be tested in your exams. So microcytic anemia, you're worried that the lady has iron deficiency. What's the next test you do? Ferritin. This is probably one of the most accurate reflections of your body iron. Serum iron, you might think, is probably the next most reasonable investigation, but actually it can be quite unreliable. Iron can vary with diurnal variation. It depends on what time of day you measure it. Even if you measure it within the same laboratory, the actual iron concentrations can be quite different. So it's not a reliable way of measuring iron concentrations. Remember, ferritin is reflective of your iron stores, because iron is stored with ferritin. So therefore, ferritin is a reflection of how much iron you have within your body. Transferrin is used for transporting iron, if we remember going back to our pathophysiology section, and that's not typically first line. Total iron binding capacity is similar to your transferrin, but again, it's not first line. Ferritin is the first thing you measure. Urinary iron is just not a thing, doesn't exist. That was made up. The other way to classify iron deficiency anemia is by the actual sort of pathophysiology. So reduced intake, increased requirement, or increased loss. And again, it's all the same causes, but it's just classified in a slightly different way. Perhaps you may prefer to classify it like this, but I much prefer the other way. I'm not going to go into this because it's all the same stuff, but if you did, the slides are on the website, so you can have a look at this. So we've gone over the features of anemia, but what are the classical features of iron deficiency anemia? There are some added things. So patients get glossitis, they get angular stomatitis, also known as angular colitis, koilonychia, and pica. So glossitis is inflammation of the tongue. I don't have a picture of that here, but the tongue becomes very red and swollen. This is angular stomatitis. So at the angle of the mouth, you have inflammation and sort of wearing away of the epithelium. Koilonychia refers to this flattening and almost spoon-shaped nails. And pica refers to craving. So people with iron deficiency anemia often experience craving. So one example is they may crave ice. So they end up eating a lot of ice, craving it for no particular reason. Some of you might think, why on earth do you get glossitis, angular stomatitis? Well, iron is involved in cellular growth. So if you don't have enough iron, you're not going to be repairing your cells as quickly. If you don't repair your cells as quickly, you can develop things like angular stomatitis and glossitis, and even nail changes, I guess. So yeah, I hope that's all clear. Next question. So which of the following is true for a patient with iron deficiency anemia? Are you going to treat them with a blood transfusion, with intravenous iron, or are you going to arrange some form of endoscopy depending on their age? So which of these is correct? I'll just just look through some of your comments in the meantime. Yeah, so pickers craving sort of weird things like ice or dirt. Someone's asked, why does glossitis occur? So I just briefly touched on that. Okay, good. So we've got a close call between over 60 colonoscopy or over 65. So NICE actually say if you're 60 or over, then you arrange an urgent colonoscopy. That should be greater than or equal to. But the point is, yeah, if you're 60 or over, you must arrange an urgent colonoscopy to screen for colorectal cancer. So remember, in an elderly patient, if they present with an iron deficiency anemia with no obvious cause, then that is colorectal cancer until proven otherwise, because the cancer can erode away at the gut wall and cause chronic bleeding. You're going to lose iron and the patient will develop an iron deficiency anemia. So these patients must undergo an urgent colonoscopy to check for cancer. You don't treat iron deficiency with a blood transfusion unless it's severe. You don't treat with intravenous iron, you treat it with oral iron. And upper GI endoscopy is only indicated if you're worried about upper GI bleeding. So what investigations are they going to do specifically for iron deficiency anemia? Well, of course, we always start off with a full blood count, and that's going to show microcytic anemia. Blood film will show hypochromic red cells, so that just means pale red blood cells, and target cells. I have an example of target cells later on, so don't worry, that will be coming up. This is the key bit though. What are you going to see in the iron studies? So NICE say the first thing you should do is check the ferritin. You don't necessarily need to check all of these other bits and pieces, but because they may come up in your exam, I've listed them here. But the ferritin, if you have less iron, you need less ferritin because your iron storage is going to go down. So you have therefore reduced ferritin. Of course, your serum iron should also be reduced in iron deficiency. Transferrin saturation, that is the carrier molecule for iron, and that will also be reduced. If you have less iron kicking around, less of that transferrin will be saturated, so this is reduced. Total iron binding capacity, if you have less iron, your binding capacity for iron will therefore increase. Okay, so TIBC is total iron binding capacity. The key point is ferritin is reduced in iron deficiency, and it's a microcytic anemia. Further investigations you might consider. So endoscopy only if you suspect some form of GI problem. This is not routine. If they're over 60, as we mentioned, then you can conduct this, or if you suspect, say, a bleeding peptic ulcer, then you can do upper GI endoscopy. But this is not a routine investigation. And again, if you suspect celiac disease, you can do special tests for celiac serology. Not a routine investigation there. Now, how do we manage these patients? So always address the underlying cause. In this young lady, she had menorrhagia. The way to stop the iron deficiency is to treat the menorrhagia. So that would go to either be treated in general practice or go to a gynecologist. But we also need to replace the iron that the patient is losing. You can do that orally, and that's first line with ferrous sulfate or ferrous fumarate. You start the patient on iron replacement and you monitor their hemoglobin 2 to 4 weeks after starting, and then at 2 to 4 months after starting. The point is you continue treatment for 3 months until the anemia has, so 3 months after the anemia is corrected. Once you correct the anemia, you carry on iron supplementation for 3 months and then you stop the iron. You can use intravenous iron replacement in certain instances where the patient does not respond to oral therapy or they are intolerant of it. Quite a few patients are intolerant of oral iron. It's not the most pleasant medication. If the patient has malabsorption, obviously they can't absorb oral iron, so you can give them intravenous iron. And in chronic kidney failure, end-stage renal failure, intravenous iron has been shown to be more effective. Okay, so that's the other indication. You can give a blood transfusion if the HB is less than 70 or less than 80 and they have cardiac problems. So the threshold for transfusion is slightly at slightly higher hemoglobin level for those who have ischemic heart disease. Just a few questions on this slide for you. So what are the common side effects of iron? Because this is commonly tested in exams. If you just list probably the most common, yeah, constipation and black stools. Those are the most common. So a patient may come in saying, I've got black stools, and you might think that's melena, but actually, if they're just, the first thing you must ask a patient who comes in with melena or black stools is, are they on oral iron? Because iron will make your stools black. And that is obviously a different story compared to an upper GI bleed. The other one is constipation, a very common complication. The other question on this slide is related to the hemoglobin threshold. So why is the hemoglobin threshold less than 80 for cardiac problems and less than 70 for other patients? Why is there a slightly different threshold given for cardiac patients? Yeah, so it's just to stop the stress on the heart, that's right. Because in patients with heart disease, their heart is already struggling. If you put an anemia on top of that, their heart's going to struggle even more, because if a patient has anemia, the way the body compensates is the heart needs to pump more blood around. In patients who have pre-existing cardiac illnesses, the heart won't be able to cope with that stress. So you transfuse them earlier compared to patients who don't have cardiac problems. Good. Next case. So we have a 1-year-old child is brought to the GP. His mother's concerned he's not gaining weight. He's dropping off the centiles on his growth chart. So for those of you who haven't done pediatrics, what that means is he's basically not gaining weight properly and he's not growing properly. So he's not really growing. He appears pale and has evidence of hepatosplenomegaly. His forehead looks like this, a quite prominent forehead. You do some investigations and you have a diagnosis of beta thalassemia major. So it's not good, okay? He's got beta thalassemia major. Let's move on to the next question. So which of the following would you expect to see on hemoglobin electrophoresis in this patient? Raised HbH, raised HbA, raised HbA2, reduced HbF, or HbS? So you need to know your hemoglobin electrophoresis results for your exams, sadly. Just trying to look through some of your questions on the chat. Okay. Good. Raised HbA2. So that is the correct answer. I'm impressed that so many of you knew that. So in beta thalassemia, your HbA2 and your HbF is raised. Your HbA is low. HbH is associated with alpha thalassemia, and HbS is sickle cell disease. Okay, we'll go into this, but the point is your HbA2 and your HbF are raised in beta thalassemia. So what is thalassemia? It's an autosomal recessive hemoglobinopathy. What does hemoglobinopathy even mean? That just means you have impaired globin chain synthesis. So remember, hemoglobin consists of 4 chains. If you have this hemoglobinopathy, there is a malfunction in the way those chains are made. It's prevalent in areas of malaria because thalassemia has been shown to be protective against malaria. Alpha thalassemia is mainly seen in Asian and African populations. So think A for alpha, A for Asian, A for African. Beta thalassemia is also seen in Asian populations, but it's also more predominant in Mediterranean and Middle Eastern individuals. So that is the structure of hemoglobin. And again, going back to the actual hemoglobin structure, we need to know this inside out, but this is what I really wanted to show. So HbA is the most common cause, is the most prevalent, structure of anemia within, most prevalent structure of hemoglobin within adults. It's in 2 alpha chains and 2 beta chains. In alpha thalassemia, as the name suggests, you can't really make the alpha chains. So every single one of these will be reduced. Alpha, alpha, alpha in each of these isoforms. If you can't make any alpha chains, each one of these isoforms or types of hemoglobin will be reduced. And that's why this table here says all of them are reduced in alpha thalassemia. In beta thalassemia, as the name suggests, you can't properly make beta chains. If you look at these structures here, the only hemoglobin isoform to contain a beta chain is HbA. So your HbA is reduced in beta thalassemia. Your HbA2 and HbF are increased, okay? So HbA is reduced, HbA2 and HbF are increased in beta thalassemia. So if we look at alpha thalassemia in a bit more detail, it's impaired synthesis of alpha globin, as we discussed. The alpha chain is not made properly. Alpha chain synthesis is controlled by 4 alleles, so 4 separate genes on chromosome 16. And it is caused by genetic deletions, and that's important because it's a slightly different mechanism from beta thalassemia. So we have lots of different types of alpha thalassemia. You have the silent carrier, where there's only 1 genetic deletion. All the levels of HbA, HbA2, and HbF are absolutely normal. So that's what the N stands for. Silent carrier is normal. They are typically asymptomatic. Alpha thalassemia trait, there are 2 deletions. HbA, HbA2, and HbF are slightly reduced. What's the most severe type of alpha thalassemia? So I haven't got it on this table yet, it will come up, but what's the most severe form of alpha thalassemia? So hydrops fetalis, yeah, so, okay. HB Bart's, it's not, hydrops fetalis is not the name for alpha thalassemia, it's HB Bart's. So silent carrier is 1 deletion, trait is 2 deletions, HBH is 3 deletions, and HB Bart's, all your alpha genes are knocked out. So all 4 of them are deleted. If we look at HBH, 3 deletions, you're going to have significantly reduced levels of HbA, HbA2, and HbF. What ends up happening is because you don't really have enough alpha chains around, your beta chains form tetramers, and those tetramers actually end up being toxic to the red blood cell. They cause red blood cell membrane damage, and you get hemolysis. And that presents with a marked anemia, and it'll typically present in young patients. HB Bart, all 4 of your alpha genes are knocked out, so you can't produce any alpha. So all 3 of these isoforms are completely absent. In this scenario, you have gamma chains forming tetramers, and the fetus will not survive if sadly they won't survive if they have HB Bart's. They will die in utero, and they develop something called hydrops fetalis, which is essentially heart failure in utero. Okay, they become very edematous, and sadly they die. So this is not compatible with life. HBH is severe, silent carrier and trait are fairly mild and asymptomatic. So that's alpha thalassemia. Now, how does that differ from beta thalassemia? Well, the chain that's affected in beta thalassemia, as the name suggests, is the beta chain. Beta synthesis is controlled by 2 alleles on chromosome 11. So remember, alpha is controlled by 4 alleles, beta is controlled by 2 alleles. What actually leads to impaired synthesis in beta thalassemia is genetic mutations. So going back to alpha thalassemia, it's 4 alleles, and impaired synthesis is caused by genetic deletions. But in beta thalassemia, it's genetic mutations. So there's a difference. These genetic mutations can lead to reduced production or completely absent production. So that's known as beta plus for reduced production, or absent production known as beta 0. 3 forms of disease: trait, intermediate, and major. I wouldn't worry too much about intermediate. It will never be tested in your exams, and it's basically just an in-between state. If we take traits first, so what this beta/beta plus thing means is you have 2 genes for 2 alleles for beta globin production. One of the genes is completely normal, as denoted by this beta sign. The other gene is mutated and produces less beta globin than it should. So you have one gene functioning completely normally, and the other gene which is producing less beta globin than it should. Therefore, you're going to have slightly reduced HBA. Okay, you're going to have reduced HBA because HBA consists of alpha and beta chains. If you can't make the beta properly, your HBA goes down. And if your HBA goes down, that means your HbA2 and HbF will go up. Typically asymptomatic or mild. Okay, so this isn't too much of a problem. Patients don't typically need any treatment. They're fairly well. They'll have maybe a mild microcytic anemia. Major is where there's a problem. So you have 2 genes, both of which aren't functioning. You can't produce any of the beta globin, so you have no HbA. You have marked increase of HbA2 and HbF. These patients have a significant anemia and present as the case did, in the youth, with failure to thrive, prominent forehead, hepatosplenomegaly, etc. So the 2 that you need to know are trait and major, and then intermediate lies somewhere in between. And this isn't an exhaustive list of all the genetic combinations. There are slightly different combinations and variations you can get. But the point is, in major, you're not producing the beta chain. In trait, you still are producing the beta chain. Okay, moving on to the next question. Which of the following is a cause of his prominent forehead? So if you go over to Mentimeter. So is it trauma, cortical thickening, normal variant, bone marrow expansion, or osteomyelitis? So this is a common symptom seen in thalassemia in general, as a prominent forehead. What is underlying that? Good, bone marrow expansion. Okay, so let's make bone marrow expansion. That's the correct answer. So what happens is, because you're not producing enough or functioning hemoglobin, there's compensatory bone marrow expansion in sites away from where you would normally produce red blood cells. So the bone marrow in your skull starts to expand to produce more hemoglobin, and that causes what's known as frontal bossing, so that prominent forehead, and you also get prominent zygomatic bones. So the zygomatic is your cheekbone. So they have very prominent facial structure. All of these other causes are incorrect. So what are the signs specific to thalassemia? Neonatal jaundice, because remember those red blood cells which contain the abnormal hemoglobin variants are susceptible to hemolysis, so they develop neonatal jaundice. They develop hepatosplenomegaly. Why do they develop hepatosplenomegaly? What's going on there? Yeah, so extramedullary hematopoiesis. In a bid to try and compensate for the anemia, your liver and spleen start producing hemoglobin, and that's known as extramedullary. hematopoiesis. Extramedullary means outside of the bone marrow, and therefore you develop a large liver and a large spleen. So that's commonly seen. Failure to thrive because they're anemic and they're not delivering oxygen to tissues properly. And this appearance of the face is known as a chipmunk facies within the medical literature. I'm not a huge fan of these words like chipmunk facies, or in Cushing's you have moon facies and buffalo hump, etc. But that's what you'll come across when you read medical textbooks. And that's the prominent forehead, also known as frontal bossing, okay? So what are we going to do to investigate a patient with thalassemia? Well, full blood count always, and they'll have a microcytic anemia. Blood film, looking at, you'll see hypochromic red cells, which just means pale red cells, target cells, and Howell-Jolly bodies. So this is a Howell-Jolly body, and it's just a nuclear remnant within the red blood cells. Remember, red blood cells don't contain nuclei. When they do have nuclear remnants, that's called a Howell-Jolly body. And these are target cells here. So the ones which have they look like kind of like Mexican hats. So I'm just circling one here. Hopefully you can see my mouse. You have this outer ring of white and a central like red bit, and that looks like a bullseye or a target, and it's known as a target cell. You can also do imaging. So if you did a skull x-ray, you'll see a hair on end appearance. So it looks like the skull has little hairs growing out of it. And again, that's because of the bone marrow expansion. So you can Google that. I don't actually have an image of that, but you can Google that. And someone's asked a good question. So target cells and Howell-Jolly bodies are pretty non-specific findings. You get target cells in iron deficiency anemia, you get Howell-Jolly bodies and lots of other conditions like particularly those which affect the spleen. Okay, so these are fairly non-specific, but just words to know because they often ask them in your exams. The diagnostic test is HB electrophoresis, which will show you the proportion of HBA, HBA2, HBF, etc. And you can also do genetic testing, but these are your sort of go-to investigations: full blood count, blood film, and HB electrophoresis. How are you going to manage these patients? Well, typically those with alpha or beta trait, so the most minor form of the disease. Trait, minor, it's all the same thing, okay? It's all referring to the same type of disease. They do not require any intervention, typically. Those with the more severe forms of disease, so HBH and beta thalassemia major, they have regular blood transfusions. They need folate supplementation because the abnormal hemoglobin variants cause red blood cells to undergo hemolysis, and that can lead to folate deficiency. So you need to replace the folic acid because folic acid is very important in building up DNA and building up red blood cells. Iron chelation, so that's an agent which basically binds iron. If you give the patient regular blood transfusions, you're at risk of giving them too much iron, and they can then develop something called hemochromatosis or iron overload. So to prevent that, you give them iron chelators, such as, I can't really pronounce that, but such as that, essentially. Splenectomy, so some patients will be eligible for splenectomy, and the reason for that is, remember, patients develop splenomegaly due to extramedullary hematopoiesis. That leads to hypersplenism, so your spleen's working super hard. That's what hypersplenism means. When your spleen is working super hard, it actually starts to eat up red blood cells. So funnily enough, it's a bit paradoxical, but your spleen starts to grow to try and help you out and produce more red blood cells. But in doing so, it actually also ends up hemolyzing other blood cells, and that can cause a problem. You don't want your spleen eating up all your blood cells. So some patients with massive splenomegaly will be eligible for a splenectomy, where you just take the spleen out. And rarely, I don't know how commonly this is actually carried out, but you can carry out a stem cell transplant as a cure. But again, stem cell transplants are a very risky procedure, so you would try and avoid this. Good. I will, so hopefully we're wrapping up in about 10 minutes or so. There's quite a lot of questions coming through, but don't worry, I'll stick around at the end for a Q&A. Anemia of chronic disease. So interestingly, this is the second most common anemia worldwide. So iron deficiency is first, anemia of chronic disease is second. And all it is anemia due to inflammation. So inflammation causing reduced red blood cell production. It's microcytic or normocytic, it can be either. So typically it's normocytic in the early stages and then it becomes microcytic later on. Second most common in worldwide, multiple causes. The prevalence of, so as an example, the prevalence of anemia of chronic disease in rheumatoid arthritis is around 30 to 40%. So it's quite common actually in rheumatoid arthritis. What are the causes? So anything which really is going to trigger your immune system and cause inflammation, autoimmune disorders, chronic infection, chronic diseases, malignancy, major trauma. So these are all your causes of anemia of chronic disease. And you'll see this extremely commonly in clinical practice. What's actually going on is you have some chronic disease process, which is leading to cytokine release. That cytokine release causes an increase in a protein called hepcidin. So this is made in the liver. When you have a chronic inflammatory process causing release of cytokines, your hepcidin will be raised. What does hepcidin do? It reduces iron absorption. It suppresses the response to erythropoietin. So erythropoietin is a hormone released by the kidney, which stimulates red blood cell production. Hepcidin suppresses that, and it also causes iron to be stored intracellularly. So you're keeping hold of your iron within the cells, you're absorbing less, and you're not responding as much to erythropoietin. What's the end result of that? So what's that going to cause? If you have reduced iron absorption, iron sequestration and suppression to erythropoietin. Yeah, so it causes, essentially it's a functional iron deficiency. They may technically have enough iron in their body, but they're not utilizing it correctly because it's all being stored away. So it's a functional iron deficiency. It's quite similar to iron deficiency anemia in that sense. How do we investigate this? So obviously you're going to investigate the underlying cause because there's something which is causing this, such as rheumatoid arthritis. But if you were to actually investigate the anemia of chronic disease, what you would see on iron studies is a raised ferritin, a reduced serum iron, reduced transferrin saturation, and reduced total iron binding capacity. Inflammatory markers would be raised because you have usually some chronic inflammatory process causing this. So if we take each one of these in turn, why is your ferritin raised? Well, remember, hepcidin causes your iron to be stored intracellularly. Ferritin is the intracellular storage compound for iron, so your ferritin levels go up. Serum iron is reduced because you're absorbing less and you're storing more of it intracellularly, so the amount in the serum goes down. Transferrin saturation is reduced because you have less iron around in the blood. Therefore, the saturation of transferrin will go down. And interestingly, your total iron binding capacity is also reduced, and I think that's because your total transferrin concentration also goes down. So your capacity to bind iron reduces. And that's a comparison of chronic anemia to iron deficiency anemia. So the main differences are at the level of ferritin. In iron deficiency, it's reduced. In chronic disease, it's raised, as we discussed. Your inflammatory markers, of course, in chronic disease are raised, and iron deficiency, I shouldn't say reduced, they're normal. Okay, in iron deficiency, your inflammatory markers are normal. Your total iron binding capacity in iron deficiency is raised, but in chronic disease, it's reduced. And that's to do with your transferrin concentration. But yeah, just learn that essentially. You would not need to know about the management of anemia of chronic disease. I've only put it in here for interest, but of course, the main point is you treat the underlying cause. Usually it's quite a mild anemia, so you may not even have to do anything. You can give iron supplementation. The British Journal of Haematology says erythropoietin can also be given, and they say blood transfusion is not typically required because the anemia is usually not severe enough. So iron supplementation or erythropoietin, if they really need it, you wouldn't typically give a blood transfusion, treat the underlying cause. Okay. So we have about 5 to 10 minutes left where we will go through the final cause of microcytic anemia, which is sideroblastic anemia. And this is the rare one, which I've never seen in clinical practice, but for some reason they like testing it in exams. And it's anemia due to defective heme synthesis within the mitochondria. So something's messed up in the mitochondria and your heme synthesis is impaired. 4 causes: congenital, it's an X-linked recessive enzyme deficiency, vitamin B6 deficiency, lead poisoning, and chronic alcohol. Does anyone know what the enzyme deficiency is? I'd be quite impressed if anyone knew this. Just type it in the chat if you do. Okay. Yeah, some of you know it. That's impressive. So ALA, what does ALA stand for? So this is what's going on in the mitochondria. The pink thing is the mitochondria. Outside is the cytoplasm of the cell. You do not need to know this in detail at all. I definitely would not learn this. I put this here for your understanding. But basically, the key thing is you have glycine and succinyl-CoA being converted to this thing called delta aminolevulinic acid by an enzyme called aminolevulinic acid synthase or synthetase. Okay. That is then converted to porphobilinogen by ALA dehydrogenase. So ALA stands for aminolevulinic acid. You then have a bunch of reactions going on in the cytoplasm, and then you come back into the mitochondria where iron combines with this final thing called protoporphyrin to form heme. And the final enzyme in that pathway is furochelatase. Again, you don't need to know this in detail at all, but the reason why it's important is because you need, in order to understand what's going on with all the different causes of sideroblastic anemia, you need to have a basic understanding of the enzymes. So congenital is a deficiency in this enzyme here, ALA synthase or synthetase. In lead poisoning, where patients have taken too much lead on board, furochelatase and ALA dehydrogenase are impaired. Vitamin B6 is a cofactor for ALA synthetase. So if you have vitamin B6 deficiency, that's going to mess up this enzyme. Alcohol in general just affects the whole mitochondria. It's a mitochondrial poison. So it's going to affect your heme synthesis. And remember, heme, if you can't make heme properly, you're going to have less hemoglobin and therefore become anemic. So the question is, what is sideroblastic? What on earth does that even mean? So the point is, your heme synthesis is affected. So what's going to happen is your iron is going to start to collect within the mitochondria and within the cell. Sideroblastic anemia, some form of enzyme impairment within the mitochondria. Your iron starts to collect within the mitochondria. And then it forms rings around the nucleus of the erythroblast. So the erythroblast is an immature red blood cell. The iron starts to collect around the nucleus, and that's these blue dots here seen on this blood film. And that appearance is known as a ringed sideroblast. That's why it's called sideroblastic anemia, okay? So the iron collects around the nucleus and it forms a sideroblast, hence it's called sideroblastic anemia. For microcytic anemia, the blood film will show ringed sideroblasts and the iron studies are listed there. But I don't want to go into that in too much detail. It's unlikely that you need to know any more than the basic sort of enzyme pathophysiology. Let's start wrapping up. If we go over to our top decile question. So if you pop your names in, so I can see some of you are asking about, normocytic and macrocytic anemias. We're going to cover them in upcoming lectures, okay? So hopefully this works. I had a bit of trouble with it recently. So the quicker you answer, the more points you get. Hopefully I've made this nice and difficult for you. Which of the following is most associated with choriocarcinoma? Iron deficiency, anemia of chronic disease, sideroblastic anemia, alpha thalassemia, or beta thalassemia? So I would say this is a fair thing for you to need to know for your exams. So you have 5 seconds left. Okay, very interesting. Alpha thalassemia, why? Does anyone know? I'd be impressed. Say, some of you might have just guessed that, but if someone could say in the chat, I would be very impressed if anyone knows why. So choriocarcinoma is a germ cell tumor derived from basically the cells that are going to go on to form the placenta. One of the risk factors for choriocarcinoma is spontaneous abortion. So ladies who have an increased number of spontaneous abortions, their risk for choriocarcinoma increases. And remember, as we said earlier, if you have HB-Bart's disease, which is the most severe form of alpha thalassemia, these patients develop in utero fetal death, they develop spontaneous abortions, and that increases your risk of choriocarcinoma. So it's multiple steps that you need to think through. You need to think alpha thalassemia, HB-Bart's disease, causes spontaneous abortions, and therefore increases your risk of choriocarcinoma. You might think that's unfair, but that's a well-recognized risk factor for choriocarcinoma. Interestingly, the prevalence of alpha thalassemia and the prevalence of choriocarcinoma overlap. So both of these are predominantly seen within China, for example. So the prevalence of both diseases overlaps, and that's because alpha thalassemia causes spontaneous abortions in HB-Bart's disease. So just an interesting fact for you. Recap, we've gone over microcytic anemia. The key ones are iron deficiency, chronic disease, and thalassemia. Sideroblastic is a bit niche, but you just need to know it. Next, so on Friday, I'll be going over hematological malignancies, but next week, I'm going to cover more of anemia. We'll go over macrocytic anemias, and then after that, we'll go over normocytic anemias. Oh yeah, the leaderboard, sorry, I did forget. Okay, well done, Father Spliffness. Very good, very impressive. Sadly, there's no prize for you, but I'm impressed that you knew that. Good. So just before we wrap up and release the feedback form, we have our QBank at app.bitemedicine.com, and that's a multi-step approach as we take in these webinars. It goes through first steps, investigations, diagnosis, management, pathology from one case. So you really get to know the case inside out. You really get to know the condition inside out. Similarly with our textbook, it goes right from the pathophysiology to the complications, like we do in these lectures. So please check that out at bitemedicine.com. There's a bunch of free content on there. There is the feedback link, QR code. Azim will post the feedback link in a second, and I will try and take some of your questions.
Thank you, Shoaib. Hello everyone, it's Azim here. Just before you dive into the Q&A, just a quick announcement is that for future webinars, these will all be hosted exclusively through the website, which you've all probably accessed via. If you had any issues with this and have needed to access it via Zoom, would you mind just emailing us at admin@biomedicine.com just with the issues that you've had, any screenshots, just so we can improve things for you guys? That'd be really, really useful. Yeah, thanks a lot.
Yes, that's an excellent point. So yeah, as Azim said, logging in through Bite Medicine to access the webinar. So any issues, please do raise them with us. It's still a work in process and we're really trying to fine tune it at the moment. So someone's asked, in anemia chronic disease, why is transferrin saturation reduced? Okay, so we go back to that slide. So the reason is, in anemia of chronic disease, your transferrin saturation is reduced because you have less iron around. Remember, it's being sequestered into your intracellular stores. If you have less iron in the blood, less of it will be binding to transferrin. So the saturation of transferrin goes down. There's less stuff bound to transferrin. So the saturation is reduced. And why is the total iron binding capacity reduced? Because in anemia of chronic disease, your transferrin concentration is also reduced. Okay, your total transferrin concentration is reduced. Therefore, your total binding capacity for iron is also reduced. Why do you get neonatal jaundice and thalassemia? Because you get hemolysis. The abnormal hemoglobin variants damage the cell membrane. You also get the spleen eating up some of those blood cells. You get hemolysis. Red blood cells release hemoglobin, which is then broken down into bilirubin. Bilirubin causes jaundice. What's the difference between blood loss from peptic ulcer or colon cancer versus acute blood loss? Okay, so in acute blood loss, you typically get a normocytic anemia, and in chronic blood loss, you're losing your iron slowly. So you get iron deficiency anemia, and then you get microcytic anemia. With the explanation of sideroblasts, I thought red blood cells don't have mitochondria. They don't. This was talking about the erythroblast, remember? So the erythroblast is the precursor to the red blood cell. So you're right. Red blood cells don't contain nuclei or anything like that, but the precursor cells all do. Sorry, why is ferritin raised in anemia of chronic disease? Because your hepcidin is causing all of your iron to be stored, not all of your iron, but a lot of your iron to be stored intracellularly. The intracellular storage molecule of iron is ferritin. So ferritin binds up all that iron, so your ferritin goes up. So how do you differentiate iron deficiency anemia from thalassemia? The presentations are quite different. So remember, thalassemia, if it's the major form, will present in young age. They'll get the frontal bossing, jaundice, hepatosplenomegaly. If it's a minor form of the disease, they can be quite difficult to distinguish. They'll both present with a microcytic anemia. But what happens usually in trait is your MCV is very low. So in patients with thalassemia traits, so alpha or beta, you typically have an MCV of less than 70. So they can have an MCV in the 60s. In iron deficiency anemia, your MCV tends to be a bit higher. Still low, but higher than what you'd see in thalassemia traits. So that's how you can distinguish between them. Ultimately, you'd have to do hemoglobin electrophoresis. So how does hypothyroidism cause anemia? So that's a macrocytic anemia, and we'll go into that next lecture. Hypothyroidism, macrocytic. Good. I think maybe I'll take one or two more questions. So in a patient with cardiac or renal failure, do you avoid blood transfusions? No, not necessarily. If they need it, you can still give it, but you'd have to give it very slowly. You may limit the amount you give, but it's not a complete, absolute contraindication. With gene deletions, wouldn't one of the other genes compensate? Well, no, because both genes are contributing to the production. So if you have a gene deletion, I mean, if we're talking about alpha thalassemia, if you have one gene deletion, it's not a problem. Remember, it's 4 genes. The other three alleles, sorry, will compensate. If you have more than one allele deletion, then it tends to become a problem. But the point is, the more genetic deletions you have, the more of a problem you're going to have, because each one of those genes is responsible for producing some of that globin chain. What is beta thalassemia minor? So it's the same as trait. They're just two different names for the same thing. Okie dokie. I think we'll wrap up there. Someone's asked, can we email you guys for advice? So yeah, you can email us for advice. You can email me at shuaib@bitemedicine.com if you had any further questions, or you can post them on our Facebook group, and we are always keen to answer them there. But thank you all for tuning in. It's been an absolute pleasure teaching you all as always. And please do tune in for our lecture tomorrow on general surgical emergencies by Azim. We will cover the rest of heme, don't worry. We'll cover malignancies, we'll cover the rest of anemia, and hopefully we'll try and simplify it for you. Otherwise, have a good evening, have a good rest, and I will see you tomorrow in the chat. Yeah, have a good day.